We're going to talk about concepts in chest x-rays and chest radiography during our next chapter. And along with that, we're going to evaluate patients with presenting with acute respiratory compromise and distress, just so you could see how the workup is done and how the chest x-ray really plays a big role in that. But let me start with some basic concepts first and some relative questions that you could find on the boards. And here's the first one. A 26-year-old man has a 2.5 centimeter calcified nodule in the right lung found on a routine chest x-ray. Now he was doing something, he got the chest x-ray. We don't get routine chest x-rays. It was a routine chest x-ray because he was employed, his employer asked for it, and it was a routine chest x-ray because everybody got their x-rays in that sense. But I don't want you to think that a chest x-ray is part of a routine physical. It's not. This patient got it because of the stuff that he was doing for work. This person has no complaints. He has never smoked, and his exam is totally unremarkable. What is the next step in this case? And I could tell you right now, the first step that you would do in this patient is to look for old chest x-ray he may have had years before or as a child, to look and confirm that that pulmonary nodule has been there, or if it wasn't there, now it becomes a different story. Generally, though, the first test to do is always to look for a pulmonary nodule on the old chest x-ray. So what is the story with pulmonary nodules, and how do we and where do we go after getting an old chest x-ray? So getting the old chest x-ray is the first thing, and if we find it there, if we find it on the old chest x-ray and it's been more than a couple of years and it's been stable, then most of us say this is, a benign pulmonary nodule, especially in this patient who's a low-risk patient, and we don't do anything about that. We may do an additional chest x-ray one more time to confirm that it doesn't change in size, and then really we don't do anything beyond that if it's been more than a couple of years since the old chest x-ray. Now, some people have asked me, well, a pulmonary nodule, if you find it on the chest x-ray, okay, it's not lung cancer all the time, but what is it? And the answer is, most of these are old lung infections. Sometimes in certain parts of the United States, for example, in the Midwest, people get blastomycosis. In the West, they get coccidiomycosis, fungal infections. Histoplasmosis is common in the South and some parts of the East Coast. So an old infection could do that. Once a patient, though, if we find a pulmonary nodule and we don't find an old chest x-ray, or the old chest x-ray doesn't show the pulmonary nodule, then the next step in evaluating this patient is to decide whether he or she is at low risk or high risk. And depending where you stratify this patient, the workup is totally different. So let me give you a couple of the stuff on this. A low-risk patient is a patient that has no smoking history, is relatively young, basically less than 45 years of age, like our patient, and has no complaints at all. What do we do with a low-risk patient? Believe it or not, we don't do anything more than get a follow-up chest x-ray every about 3 months for 2 years. And then if the pulmonary nodule is stable, then we stop the follow-up and we say this is a benign pulmonary nodule. So let me say this again. In a low-risk patient, what do I mean by low risk? Young patient, generally less than 40 to 45 years of age. A non-smoking history, they have to be non-smokers, and no complaints, no symptoms, that patient is considered, for your purposes, a low-risk patient. And what do? We follow up with chest x-rays every 3 months for 2 years, and then if that pulmonary nodule doesn't change in size, then what we do is forget about it and we say it's a benign pulmonary nodule. On the other side of the coin are the high-risk patients. Now, these are generally people over 45 or over. They have a significant smoking history, and we'll talk about this later in the pulmonary section, but the lung cancer is associated with tobacco, with smoking. So now this patient is over 45, has a significant smoking history. That is a high-risk patient. And what you do for this patient is, I know it sounds a little bit aggressive, but you do an open lung biopsy and remove the nodule. They will be specific that it's usually a peripheral pulmonary nodule. They're trying to help you out there, trying to tell you, look, if you do a bronchoscopy, you're not going to get to it anyway. You're not going to get the results you want. So let me go back and explain this a little bit. The high-risk patient has a new pulmonary nodule, or you don't have an old x-ray showing the same pulmonary nodule, or you don't have a chest x-ray in the past at all, that patient has cancer until proven otherwise because of his or her history. If you do a bronchoscopy on that patient, then you may get a non-diagnostic inflammatory process. Because a bronchoscopy is done, it's a blind biopsy, sometimes the yield is not good and you may not get to the cancer and make the diagnosis. So even if the bronchoscopy is negative and it shows just inflammatory cells or inflammatory process, that patient could still have cancer. So what I'm really trying to tell you is no matter what those results from the bronchoscopy are, you're going to still have to get lung tissue and remove the nodule. If the bronchoscopy is positive, it shows cancer, you're going to have to do an open lung biopsy and remove the nodule. So you're going back to the same case that we did here. You're going back to the same scenario. So please, in a high-risk patient, don't go for bronchoscopy first. Don't go for a CAT scan in terms of deciding if this is cancer or not. You may go for a CAT scan to see how big the nodule is, where the extent is, to see if there's other nodules you need to biopsy. But to tell you if this is cancer or not, the CAT scan can't tell you that. The bronchoscopy likely will not tell you. So what do you do in a high-risk patient with a new onset pulmonary nodule? Then you go for an open lung biopsy and you remove the nodule. In clinical practice, in reality, sometimes, so we don't do a more aggressive procedure, which is the open lung biopsy, in certain nodules that are centrally located, so now you have a better access with the bronchoscopy, you may be able to say, okay, let me try the bronchoscopy first, see if I could get a good yield, see if I could diagnose the cancer this way, and then try to forego the open lung biopsy. But they're not going to ask you that. I'm telling you again, they're going to give you a peripheral nodule, and a peripheral nodule in a high-risk patient is cancer until proven otherwise. You go for an open lung biopsy. Again, just like the bottom of the slide refers to it, be careful because bronchoscopy results in high-risk patients are non-diagnostic commonly because it is a blind biopsy. And in the end, whatever you get on that biopsy, whether it's cancer or not cancer, you're going to still have to do an open lung biopsy and remove the nodule. A lung nodule may be one of the first, the few times that you have a resectable lung cancer. So please don't miss that. Again, what do we do in a high-risk patient? We do an open lung biopsy and remove the nodule. What do we do in a low-risk patient? They're not smokers, they're young. We follow up the chest x-ray every 3 months for 2 years and then stop after that, do nothing more. So that's the pulmonary nodules. Also, please be careful. There's some, I know people ask me all the time, and there is some mention, the type of calcification that you see on the CAT scan or the chest x-ray may be more malignant or less malignant related. So what I'm saying is, so for example, some people with what are called popcorn calcifications, spickled patterns and stuff like that may be more or less associated with malignancy. You will not have to know that, because the bottom line is, even if there's calcifications there, even if they look less malignant, more benign, you're still going to have to make sure that this patient doesn't have cancer in a high-risk patient, so you have to remove the nodule. Be careful of that. They could try to tell you this patient has popcorn calcifications or something calcification. It doesn't really matter. In the end, you're going to have to get tissue and you're going to have to remove that nodule. So please be careful on that. So x-ray first and then stratify the patient. Are they low risk or high risk? And then decide what to do based on which category they fit into. In real clinical practice, you will see the third group, which are intermediate patients, and that's probably most of the patients that we see. They don't fall totally into low risk group, and they don't fall totally in the high risk group. They fall into an intermediate risk patients, and then those patients you could do other stuff, maybe bronchoscopies, CAT scans and stuff like that, but they will not give you those patients because the theory behind this is they want you to know not to miss a pulmonary nodule and assume it's benign in a patient with cancer. So they're going to give you the low risk or high risk, nothing in between. The next case I want to discuss is and talk about is pleural effusion. That's another very important subject on the boards and in clinical practice because we see all the time these patients commonly being mismanaged. So here's the case. A 65-year-old man presents with dyspnea and pleuritic chest pain over 1 month. He has also noticed a 20-pound weight loss. You find decreased air entry in the right lower lobe. A chest x-ray confirms that there's a pleural effusion there. And then you do a decubitus x-ray which shows a free-flowing fluid of approximately 3 centimeters. So they did here for you the most important test, what you do first after you find a pleural effusion. And the answer is you do decubitus x-rays to see if there's free-flowing fluid. Anything equal to or above 1 centimeter on the chest x-ray, on the decubitus chest x-ray that layers out, you could go and do what the next appropriate step is, which is a thoracocentesis. So in this case here, to go back here, the next appropriate step in this case is to go and do a thoracocentesis because they've done the decubitus chest x-ray for you. Please be careful. If a patient has a pleural effusion and you do a decubitus chest x-ray and the fluid doesn't free flow, there's no free flow of fluid, so it means it's loculated. It's still an effusion, but it's loculated because it's been there for a long time maybe, or because it's infected or it's complicated. If you do a thoracocentesis in that patient, you are likely more to get complications from the thoracocentesis rather than get fluid out and make a diagnosis or confirm a diagnosis. So be careful. If a patient has a pleural effusion, right, and you do a decubitus x-ray and the free-flowing fluid is not there, there's no free-flowing fluid, you go next and you do under ultrasound-guided thoracocentesis. You don't do a thoracocentesis yourself. You talk to the radiologist. They go in with the ultrasound. They find a pocket of free-flowing fluid somewhere in there, and they do a thoracocentesis under ultrasound-guided in order not to cause any complications. But in this case, it's different. We have the typical pleural effusion. We have the decubitus x-ray showing free flow. What is the next appropriate step? Always a thoracocentesis. We should never, ever not do a thoracocentesis in free-flowing fluid, whether it's in the middle of the night when we find the patient or the next day or whatever. As soon as you find a pleural effusion, you have to do thoracocentesis always, always, and immediately. Please be careful of that because they may show you about they may talk to you about a case where you have an effusion, and they tell you you may want to wait a day or two and stuff like that. You don't want to do that. I'll explain all the scenarios, but you never ever want to do that. You want to do thoracocentesis immediately, as long as there's free-flowing fluid. And if there's not, you need to do ultrasound-guided thoracocentesis immediately also. So let's talk about effusion because this is very important. Why do we get the thoracocentesis fluid? Well, the first thing is because we want to tell the difference between a transudative process and an exudative process. That's the first and foremost thing. So, for example, a transudative process means systemic factors are involved in causing the effusion, like nephrotic syndrome, like cirrhosis, like congestive heart failure. For example, things that cause increased hydrostatic pressure or decreased oncotic pressure, like the nephrotic syndrome, you're losing albumin. So any systemic factors that cause increase in hydrostatic pressure or low oncotic pressure will cause what is called a transudative effusion. Well, think about it. If it's a systemic diseases, then the effusion is transudative, but it should also be equal on both sides, because you should have 2 effusions if there's systemic reasons, like low oncotic pressure. So you should have 2 equal effusion on both sides. Our patient here didn't have that. So right away you should be thinking, even before the thoracocentesis, I probably think what the likely cause in this case is. It's probably not a transudative effusion, because transudative effusions, they're systemic effusions caused by systemic disease, and they're equal on both sides. And we confirm that by running a couple of things on the thoracocentesis fluid. And we get the LDH from the effusion, then we get the LDH from the effusion, and we compare it to the LDH in the serum, and then the third thing that we get is the protein from the thoracocentesis fluid, and then we get the protein in the serum and do a ratio of that. So how many tests do we need to confirm a transudate? We need basically 3 tests from the thoracocentesis fluid and 2 tests from the serum. We need the LDH from the effusion, right? Then we need the LDH in the effusion, and I call this a test really, right, to basically say an LDH in the effusion and compare it to the LDH in the serum, and then the protein in the effusion and compare it to the protein in the serum. So really, we need 2 tests in the thoracocentesis fluid, right, and 2 tests in the serum. The numbers to remember is for an LDH, 200, and then the LDH of the effusion to the serum, 0.6, and then the protein to the serum